where this is our second IMX Talks, and we've got a nice, a very impressive, I believe, panel to join us today. And thank you very much for all of your questions as well that we've already received. I think it's around 60 now, so there's going to be a lot to get through this morning. Before I do that, I of course would like to acknowledge the Gadigal people of the Eora Nation, the traditional custodians of the land, and pay my respects to the elders, both past and present. And of course, you know, as we meet today virtually, so we're together but separated by this virus. So, but it's great because it means that that we can all join regardless. So we're going to have a really robust discussion, and to do that, I'm going to introduce you now to our MC, Dr. Tim Smythe.
Thank you, Bern, and good morning to our panellists and participants in Australia, and of course, good evening, Tuesday evening yesterday to Dr. Erkan Hassan, who's in the United States. I'm in lockdown Melbourne, and my Zoom background is a memory of a holiday in Italy last year. It's not a major waterfront development in Portsea on the Mornington Peninsula in Victoria, if you're worried about that. Apart from the continuing importance of looking after our mental health, it's Mental Health Month in October. During these COVID times, my priority objective when the Melbourne lockdown ends is to get a haircut at long last. You'll be pleased to know that I've no intention of being a hapless Chris Wallace in the repeat of the Trump-Biden presidential non-debate. And Erkan might have a view on whether telehealth and virtual care could have avoided the need for the Marine One helicopter ride to and from Walter Reed, but perhaps that's for another time. Our webinar today is being recorded, and we will send you details of how to revisit the discussion with your colleagues later this week. Thank you very much for submitting the questions online when you registered, and I've tried to weave a number of those common themes into our discussion today. If you want to submit a question during the webinar this morning, please use the Q&A button on the bottom of your Zoom screen. Do not use the chat button. Please use the Q&A button. And we have about 30 minutes for discussion with the panel, and then hopefully some time to address questions, both the ones that have come in today and the ones when you registered. I'm asking Bern to monitor those questions and flag some of the key ones for me. Well, we have a great panel with us, so I'd like to introduce you to our panel. Dr. Erkan Hassan is based in Baltimore on the US East Coast. He's a pharmacist and has over 2 decades experience of working with health systems in healthcare transformation, leadership engagement, innovation, and in telehealth. He's been an innovator in approaches to sepsis management and critical care, helping develop the first United States tele-ICU system, and he's also a fellow of the American College of Critical Care Medicine. Dr. Justin Bauer is an emergency medicine specialist in Sydney and founder and medical director of the telehealth My Emergency Doctor service, providing access to emergency specialist consultations for patients, parents and clinicians across a wide variety of care settings and locations. Donna Parks is based in rural Western New South Wales, but has a statewide role as a telehealth manager with the New South Wales Agency for Clinical Innovation. She worked with a number of non-government organisations before joining Western New South Wales Local Health District in 2015 to lead an integrated care project, and then moved to her ACI role in late 2017. Dr. Mukesh Harkawal is a well-known doctor in Australian healthcare policy, innovation and system improvement. Maintaining frontline experience as a busy Melbourne GP, Mukesh has also been state and federal president of the Australian Medical Association. He appears regularly in the media, particularly in Melbourne currently, lately often in PPE at his practice COVID testing clinic. Richard Taggart is a pharmacist by background and former industry lead in healthcare for Apple in Australia and New Zealand. He was appointed CIO of the Sydney Local Health District at the beginning of 2019, beating COVID-19's arrival by only weeks. Richard has played a major role in getting Royal Prince Alfred Hospital's virtual hospital, RPA Virtual, up and running this year. Well, a starting point that I've discussed with the panel before the webinar is that our panellists and our audience today are already agreed about the benefits, the need and the value of telehealth, digital health, virtual care, whatever we're going to call it in the end. So we don't really need to discuss the why do it aspect. We know that COVID-19 has accelerated interest, but in Australia over the past 6 months, it's been largely the use of the Medicare funded GP and specialist teleconsultations, with the majority of those being telephone rather than video. So what I'd like to focus on in our webinar this morning is more on what is holding us back and what needs to happen. Funding models, clinician take-up, consumer adoption, technology, policy-wise, the things that you've raised in your questions when you registered, to both remove the roadblocks but also to drive progress. And all of our panellists have been involved in telehealth well before COVID-19. They'll all agree COVID-19 has one of the few pluses of COVID-19 has been bringing telehealth more into the foreground. So I thought I'd start off by exploring with our panellists why they got involved in telehealth and perhaps what might be some of the key things that they've learnt in their journey so far, and then we might talk a bit more about roadblocks going forward. So perhaps Erkan, starting with you, what got you involved in telehealth? My understanding is the telehealth ICU was actually almost 20 years ago.
Yeah, thank you. Thank you, Tim. And thank you everyone for inviting me. Thank you, Bernie, for inviting me. It's a pleasure to be here with you this evening and morning. I spent my whole professional career in critical care, and serendipitously met two intensivists who had this brilliant brainstorm to do telemedicine for ICU patients to leverage a limited resource and to use the technology to leverage a limited resource. The ICU only accounts for 10% of the beds in a hospital, but it is 4 times the cost of a floor bed. So it's one of the most expensive beds in the hospital and the least number of beds, but it's the most expensive. And so anything that we can do to improve the care of those patients really is going to have a dramatic impact on the quality of care as well as the financial aspect of it. And we grew this from literally 0 to cover 500 hospitals, 700 ICUs, 7,000 adult ICU beds in the US. 1 out of every 8 adult patients that go into an ICU went into one of our tele-ICU network beds. And there's lots of statistics in terms of the outcomes of these patients. There's a 30% drop in ICU length of stay using a proactive tele-ICU. There's a 26% drop in mortality, but I think the telling statistic really is we had 700 ICUs, and what our sites were telling us, our clinicians on the forefront were telling us, was that 1 to 2 patients per week per ICU. So let me say again, 700 ICUs. So 1 to 2 patients per week times 700 ICUs were walking out alive who previously died before having the system.
So in terms of that success story, what do you sort of see as the key ingredients of the success there?
There's actually several key factors to this. And when people talk about telemedicine and telehealth, they get this mental picture of sophisticated walls of computers and technology and whatnot. And that's really not the key.
That's what Richard's got. We'll come to that.
The key is really several, I mean, I can boil it down to a couple of, I'll give you the top 3. There's more than 3. But the top 3, in my opinion, are: number 1, driving best practices and standardization, decreasing the variability of care. And things that we know should be done, such as low tidal ventilation, low tidal volume ventilation in the US is only 55%, done 55% of the time. If we drive those best practices, we will avoid complications and improve outcomes. Number 2 is earlier identification and intervention to prevent deterioration. And I think that's where the future is going to lead us. We've only started to scratch the surface on that, but being able to have an earlier notification, identification that a patient is starting to veer off track and be able to intervene and bring them back on course, I think is important. And number 3 is communication. I believe communication in healthcare is awful. And oftentimes in the US, a intensivist will come in the morning, see their patient for 10, 15 minutes, and is in their office the rest of the day. So although a care plan is developed, there's really no formal mechanism to continue to expedite the care plan as the managing physician has has decided upon. And with 24-hour telehealth coverage, we find that we're able to do that. And the care plan for these patients is typically one of two things. It's either a well-kept secret, or it's micromanaged. And so if we're able to better communicate to everyone who touches the patient what the care plan is, drive that, we should have better outcomes.
Thanks, great for that. And one of my observations there is that in your top three, it's not the technology. It's other factors that are really making the difference and the reasons for doing it. Mukesh, might turn to you. You were writing before COVID arrived about the opportunities for telehealth after and during bushfires and other sort of natural disasters. What got you involved and interested in telehealth, and perhaps what do you see needs to happen in the next couple of years in Australian general practice to take it forward?
Thanks, Tim, and good morning, everybody, and thank you very much for the invitation to speak today. I suppose my life of late has been as an evangelist for the use of technology in health, and I've certainly interfaced with pretty much everybody on this conversation, and probably many people listening in that time from way back. You know, we've brought technology to health, for instance, in our general practice primary care area, going from hardly anybody using technology at all to 98% using technology for their daily work. The bringing in of video really came in earnest around 2010, when there was a big move to bring tele into normal consultations. There was the first effort by the federal government to provide patients with a rebate for doing a consultation using video and so on. So to me, it's always been a no-brainer, because it means you can do many parts of your daily work without troubling people to make an appointment, wait, come in, wait, see somebody, wait, go to, you know, all the various bits of the journey can be streamlined by using video. And it's a much richer experience when you've got video and you've got contact, eye contact, facial expressions. You can get a lot more than simply going onto the phone, which, don't get me wrong, is still a fabulous device, but there's so much enhancement by using video. So I've been part of trying to prepare people for this for quite some time. And the first time round, we probably didn't get it right because people were supported with a rebate for very minimal interfaces, so that it wasn't properly rolled out. My paper in January said, look, we've got a large proportion of our country suffered from bushfires and floods and other natural disasters. We had, unfortunately, had it all in recent months. And then, of course, COVID came along and multiplied the disaster by multiple factors. But what I was saying is that if we're doing this, we should do it properly. We should make sure people are supported to do telehealth, to do it in a way that is orderly, and you've got some rigor to this in your record keeping, in the way in which you interoperate one system to the other, because you want people to be able to simply do a video like they simply do a phone call. And I think that, you know, we know that if you pick up one brand of a mobile phone, you can ring a mobile phone with a different brand and a different carrier, and there's no problem. And so to me, it was that joining up the system and the dots by making everyone be able to participate and benefit from this, because the benefits are huge. It's not just financial, it's actually timely, pertinent healthcare at the time that you need it, with the right person that you want to see, bringing other people into that consult if you need to, which I'm sure Erkan would have seen in the intensives area, and I'm sure Richard would have seen in the area that he's working with, and obviously Donna's coordinating all these sorts of things, and Justin is right in the middle of it as well, of course, in the emergency department.
A number of points that I can see the other panelists nodding, and I'll come to soon Donna. I'm sure she will reiterate a number of those points. I just point out that it depends which country you're in. Is calling yourself a tele-evangelist may not be the right name to use in the United States at the present time, but welcome tele-evangelists to the panel. Donna, how did you get involved, or why did you get involved in telehealth is probably the more important question. And what changes have flowed from your work with the ACI, particularly in terms of clinician and patient engagement and involvement?
Yeah, look, thank you. And again, thanks everybody for the opportunity today, and good morning to you from Wiradjuri land here in Dubbo. Look, I think, you know, just out of necessity, and one of the key things around telehealth is that gives you the opportunity to, if I go back a step, it's the most underutilised tool that we have had at our fingertips for many years. It gives us that opportunity to give people the access to the right care at the right time, close to home. Now, we know from, you know, the way that people recover, that if they've got their loved ones around them, their recovery journey is so much better for them. And that ability to integrate extensive parts of the care workforce is really important. So for me, it was really about, you know, I live and work in a rural community. It's always been a part of my life, either as a patient or as a healthcare provider. So, you know, was said earlier, it was a bit of a no-brainer, really. From ACI's perspective, you know, over the last, I mean, certainly New South Wales Health, we've had a strategy in place since 2016. There was a big review that happened in 2015 that was commissioned by the Ministry of Health, and it really identified some of those key barriers and challenges that the system had in relation to that. So really what we've actually been able to achieve over that period of time is a bit more around consistency, education for our clinicians, and looking at that patient experience more often to have it as a part of a co-design approach, and understanding what is of value to patients at this time.
Not asking you to name names at all, but from your experience with leading telehealth in the ACI, what sort of types of clinicians or professions have sort of jumped on it, and which are the ones that you really want to sort of get a bit more progress happening?
Look, prior to COVID, it was a bit like a scattergun. Certainly, we had a lot of clinicians across every specialty, but there was no consistency. So, for instance, you wouldn't have a paediatrician in every LHD that was doing it. Now we do, obviously. You know, COVID has been that silver lining, if there is one, with the pandemic. But, you know, for my mind now, our biggest challenge is really around that those clinics where, whether they're operation pre-anaesthetic clinics that are a bit of a challenge to get the same throughput and those types of things, but it gives us that opportunity to integrate that in with their regular primary care providers as well, and outpatient clinics. You know, nobody likes, I mean, we've all had that experience of going to an outpatient clinic and spending 2 hours in the waiting room. Like we do it.
Working as a senior medical officer, going to the outpatient clinic, you hate it.
It's bedlam. It's so chaotic, and it's, you know, I remember going to a dentist once, and there was a sign that said, "My time is important. So if you choose not to attend, then you'll still be charged." And I thought, my time's important too, and why am I still sitting here 45 minutes later? You know, that sort of stuff. So
that one, when I was a kid in Canberra, the dentist we went to had a sign in the waiting room said, "Smile now, you won't feel like it later."
So yeah, look, I just think it's such an opportunistic time for us. And look, you know, every specialty now has really caught on. Prior to COVID, I used to hear, geez, if I only knew this, I would have been using this 5 years ago. We've had so many advancements, and I think that's probably the benefit as well. Got a long way to go.
Yep, I'll come back to you a little later about where New South Wales Health is putting its focus over the next few years in the virtual care accelerators. So Richard, with RPA Virtual, now with Apple, you've obviously had an involvement in health, but what got you into the telehealth side of things, and in RPA Virtual, in sort of getting that up and running? It's obviously been a team effort and not just solely yourself. I'm also interested sort of perhaps what impact has it had on changing the role of, say, nurses or other health professionals in that process.
Yeah, thanks, Tim, and good morning, everybody. Good to be here. I think focusing on RPA Virtual is probably the best example for me to start with, because like most of the people on the panel, we've been dabbling here with telehealth modalities for a long time, but really RPA Virtual was putting in some skin in the game and going all in. And the reason why RPA Virtual came about was we were looking at our clinical services plan and the future forecasted growth in the number of hospital beds, the number of ED beds that we would need in our facilities. And we realized that we would have to build another hospital the size of Royal Prince Alfred to cope with the demand. And that's just not sustainable, not just from a financial point of view, but running the system. It's also not the best possible experience that we can deliver patients today. So in early January, February, we decided to stand up a virtual hospital on the RPA campus with the idea of wrapping around all of the different services that we can offer to patients so that we can run hospital avoidance strategies, we could do early discharge, or we could run outpatient clinics virtually. And our original ambition, which we thought was ambitious at the time, was to see 1,000 patients in the first 12 months. We signed up Menzies Institute to do a formal evaluation. And then by mid-February, we were very much in the front line of responding to COVID-19. Two reasons for that. One, because of our location and because we're so close to the airports and because we're in the city of Sydney. But secondly was because we took over the quarantine hotels and the care of patients in quarantine hotels who either had COVID-19 or they had other health conditions. And so between about the 4th of February, when we formally opened the doors of RPA Virtual to today, we've seen well over 4,000 patients, including 1,000 COVID-19 positive patients. And we've seen all sorts of different cohorts far beyond what we originally planned. And the results have been quite astounding. To your final point of your question, Tim, I think what's the most exciting part is some of the nursing and the allied health models that have started to emerge from the work that we're doing. These are the ones that are actually using the more interesting elements of technology, not to take anything away from my medical colleagues who are using video very well, but they're starting to use more wearables, more artificial intelligence, more different modalities in care for nursing and allied health, which is very exciting, including using artificial intelligence for wound management and video consultations and video apps for exercise prescriptions and the like, but lots of opportunity, I think.
Thanks, Richard. Come to Justin, but I might drop back a little later to just a quick question for Richard and Erkan is sort of about scale, is when are there too many ICUs and when are there too many virtual hospitals? And maybe RPA's got a business plan to run RPA virtual across Australia, but we'll see. But Justin, my emergency doctor is that what got you involved in telehealth? What was the driver there? And I've noticed that your service has been contracted by a number of primary health networks to help support and supplement after hours care for their communities. And I'm interested in your views about sort of where you see it going.
Well, thanks for that, Tim, and thanks very much, everyone, for having me aboard. Look, it was about 5 years ago, and I was on duty at 2 in the morning in the emergency department, as doctors do in the emergency department, and I saw this little kid with a rash. It was as simple as this, and the kid and her parents had been waiting sort of 5 hours to see me. The parents were genuinely worried that she had meningitis, and it took me as a senior doctor probably 2 minutes to see that the kid did not have meningitis and the kid was fine. It was a really simple viral rash, and for God's sake, I didn't even have to touch the kid. And I thought, this is ridiculous. You know, as I was walking out the door, it occurred to me, it's a medieval paradigm. You know, when you think about it, that the sickest people in the community as pilgrims have to come to me. You know, that's wrong. And not only that, you know, think about those 30% of Australians who've lost the postcode lottery and they live rural and remotely without easy access to a senior emergency doctor. So I thought, look, that's not patient-centered care. You know, in emergency departments, we already station, it's nothing new. We've been stationing the most senior doctors at triage when we can, just to rapidly get to the crux and sort out the patient very fast. So why not go one step further? Everyone's got a smartphone. Why can't I just go to them? So I sat down with a bunch of my colleagues and we said, let's do this. And the key for us, you know, I'll probably echo what Erkan said, but I'd go one step further and say it's not about anything to do with technology. It's about the clinician. It's about getting the right clinician to the right patient at the right time. And that's what we do. So
what might you see as the appropriate sort of clinical boundaries, not set in concrete, obviously, but between virtual care and face-to-face care, taking after-hours emergency medicine as sort of what are the current limits?
Look, I think there is no, what's the word? There's certainly no substitute for a face-to-face, hands-on consultation. But that's why you actually have to have, well, for our model, we actually have to have the most senior doctors available. Because you think about it, I mean, I'll speak to those of us who are doctors or clinicians. You know, half of us when we were junior were scared of everything and would order a gazillion tests that weren't needed. And the other half were cowboys and would just cut corners atrociously. And you can't have either of that. You know, there's no substitute for experience except experience itself. So, you know, and it's not just about the patient. In a country like Australia, it's about the system too. You think about it, and for every patient that I managed to keep in a small rural nurse-led emergency department, that's another patient and their family that didn't need to go to the big emergency department 3 hours down the road. And that's a rural community that didn't lose their ambulance for the next 3 hours while someone's having a heart attack in the corner.
Yeah. Some of the questions on that we'd had and online, I'll come to you in a minute, okay, is that issues about privacy and cybersecurity. I think we'd all agree as a panel that they're very important issues, and they're a given that we've still got a lot of work to do on that. But Erkan, I was interested in getting your comment on presumably Justin's comments there. And also in our discussion before the webinar started, you were indicating that one of the things we need to think of post-COVID, whenever post-COVID actually occurs, is that we need to look at recalibrating what's happening in the telehealth world, and there's still a great need for more standardisation. But Erkan,
Yeah, I'll just take a couple of minutes. I think a couple of things Justin said really resonated with me. I mean, number one is we never said this was, our intent was always, this was an extra layer. And the idea was never we are taking anything away from the bedside. And oftentimes a lot of places we would start with a tele-ICU. The initial response is, oh, Big Brother's watching, or they're trying to catch a mistake, or it's the idea of cutting nursing ratios or staff ratios and stuff. And there was actually, I recall one site who the hospital administration decided to cut nursing ratios. Our recommendation is never to do that. We are always, always, always an extra layer, never take anything away from the bedside. And the one site that cut the nursing ratios, it was a disaster. And they quickly went back to restoring the nursing ratio. So it's never about replacing it. And, you know, it is leveraging the technology. The other thing that Justin said that really resonated with me was the lack of physical examination. And a lot of our tele-ICU physicians basically describe it as, and the camera we used was very high definition, night vision. You know, an ICU room is very small, but at night you want to be able to check on the patient without turning the lights on, waking them up. It had infrared, you could zoom. We could measure pupillary size with the camera that we used in the room. But and a lot of the physicians, they stated it's like being at the bedside with my hands in my pockets and seeing the patient with my hands in my pocket. And if you think about it, especially with a lot of the devices that are out there now, I have the nurses at the bedside to tell me what the breath sound like. I have other people there, and we're, again, not taking anything away. Do I really need, how much do I really need to touch the patient to see that? What was the other question? Oh, the recalibration. Yeah.
Recalibration. Yeah.
So I think we're entering a new stage, especially post-COVID. And I think that patients in the outpatient are expecting, I think they're very comfortable with using the technology and the experience that they've had to go through with COVID. They're used to it now, and they appreciate it. They like it. They participate in telehealth. They perceive it as effective. They are worried about privacy, like you brought up. But I think there's a recalibration between what is the right proportion of virtual visits versus in-person visits. And there's a number of factors that impact on that. But I think also that patients are looking for a different experience virtually than they are looking for in person. They're looking for examples include such things as, Tim, your background. Do I want my physician's background or provider's background to be on vacation scenes, or do I want it a little bit more, you know, look like a regular examination room? What are the procedures for that? And I want my provider to, I want to make sure virtually as a patient, I want to make sure my provider that I'm being heard, that they're listening to me. I want some, and clinicians have to understand that what they have to figure out is, how do I establish virtual rapport with my patient? Empathy, listening, eye contact, that my patient is being heard. So I think that recalibration has to occur, coupled with what percentage do I have in person, because I still have brick and mortar rent to pay. Perhaps there will be consolidation of physical practices. And it's also, I think, based on the type of practice. The more cognitive skill practices, such as mental health and psych, those are more amenable to virtual visits than the more procedure-oriented practices, such as orthopedics.
Yeah. Not doing colonoscopies at home just yet, but anyway. Let's see. Makesh, interested in looking at some of the questions that have been submitted, both now and as people registered. One of the issues was about access to telehealth, and it's commonly said that older patients can't cope. What's been your experience and general practice generally on that issue?
Thanks, and thanks for the discussion. It's been great. And can I just say that I spotted that George Margelis is on, so this is a real e-health conference now, so thank you for being there, George. Just to say, age is not a barrier. We're always told that, but actually older folk, and by the way, we're all getting that way now, are actually able to use the technology.
You don't have to remind Bern, she's still young.
She can manage these things quite well. My mum's in her 80s. She does that. I show people using this very same setup, walk them through with their smartphone, get them onto my platform and speak to them, and they love it. Because now they've actually got that rich, deep consultation with images. They can show me things, but they can actually see from my intonation what it is I'm meaning about the consultation. And even our work colleagues are doing this and doing it well. And it's actually some of the younger people may not be able to cope because they've got so many other things they're trying to tackle, and they need support. In fact, everybody needs support. It's not easy, it's not falling off a log. And if you use the technology, it's there. But ultimately, as we've said throughout this conversation, the technology is a very small part of it. The bigger bit is, how do you get your system to work? How do you bill for it? How do you make sure that people understand the hands-off and the need for an opportunity to have that face-to-face later on? We absolutely need to have the gold standard consultation with examination. And it's always an adjunct. It's never been a replacement. And as long as we see it that way, and see we use all the tools that are at our disposal to make the patient journey better, to make the clinicians work easier, and to make sure the care is joined up, then we've actually absolutely making a significant impact on health and health outcomes. And remembering the future isn't about the immediate acute stuff, and God bless you in emergency and ICU, it's absolutely important, but it's about prevention, it's about keep wellness, it's about chronic disease management. It's the big killers in our society. It's not COVID, it's chronic disease. And
that's a good segue into another theme in some of the questions that we've received, is how to link or coordinate across care settings, particularly aged care and healthcare. So interested, Richard, about what plans does RPA Virtual have that will actually have patients in residential aged care facilities, and working partnership perhaps with aged care providers so that virtual care comes to our aged care sector, both at home as well as in care facilities?
Yeah, it's actually something we're very passionate about. We've been running a residential aged care facility outreach service for a number of years now, using either telephone or video conferencing to engage with residents as they might be triaged before coming into one of our facilities. What's been good about COVID, one of the positives, is that those residential aged care facilities have also lifted their game from a technology point of view, so that we've been able to reach into the 60, 70 or so residential aged care facilities in the vicinity of our hospitals and really strengthen the relationships with the clinicians and the staff who work in them. We get to know the residents and help them with triaging and other health and wellness reasons. And what we're starting to work on now is how we can have multidisciplinary team meetings involving the general practitioner, because we really feel that the GP has such an important role to play in supporting that broader ecosystem around residential aged care facilities. Very excited about what we're seeing there in Sydney.
It certainly seems to have been an opportunity missed in Victoria. Donna, I was going to come back to you to ask about particularly the focus of New South Wales Health. I know you're not the Minister and the Secretary of the Ministry, but your perceptions about what the key areas of focus New South Wales has in telehealth. And I understand there's quite a bit of sharing between the states, which we don't often hear.
Yeah, look, certainly New South Wales Health sees this as a great opportunity and has really invested in that, which is fabulous. One of the key things that has happened is we have obviously a lot of the key influences and the key components of our, massive structure are all working together around making sure that it is, something that is actually embedded as a part of clinical care moving forward. So, a lot of work's happened around what are our, identified priorities, massive investment into evaluation. Never before have we had, virtual care evaluated in the way that it is. We're certainly spending a lot of time looking at evidence and what is that showing us as well. A lot of work happening around our workforce, infrastructure, obviously. Wouldn't it be great to have a digital front door, for everybody in our state, where we have intuitive, interoperable systems, like, that's, the end goal really, and really supporting innovation. So looking at those things that, really give people great access and flexibility to their care, giving them the right person at the right time, close to home. For us, it's that is really the focus, and that is centred around our workforce, making sure that they're really confident users, and ensuring that, it doesn't, it is, something that it's not replacing. It is not a secondary service either, and that it can be delivered in a way that's actually meaningful and doesn't extend the patient's journey, that's, integrated, and that, it really enhances, the source of truth. And so it really, you can be, on holidays in Queensland, but still be connecting to your regular GP. That is really.
Yeah, well, Donna,
really
you can be on holidays in Queensland. We're not allowed.
Yeah.
To. But that's another issue. A couple of quick questions as we come to a close. And another comment in the questions that we've received has been about building patient engagement in their own care. And I was reading, it was a short little article from a guy in the English NHS, and he was posing the question, will telehealth actually increase patient dependency, and people will have all these wearables and everything around their home? They won't have to worry about their care because they know if there's a problem, somebody's going to bing them, buzz them, or do something. And how do we actually think about weaning people off telehealth? So I just wondered if any of the panelists have got a sort of a 20, 30-second comment about that. Is that a risk we've got to think about? Erkan.
I think the other way around with that. I think, you have to be careful, especially with asynchronous telemedicine, in that I often talk to people who have developed remote patient monitoring tools, and they're like, oh, look, it measures your everything, and it's on your phone, and we send it to your physician, we send it to your family member, and they'll know if it's abnormal. And my response to that is, okay, so I'm a clinician, I've got 500 diabetics, and you've taken this widget, and now you can rank patients red, yellow, green. And historically, 15% of your patients are going to be red. So as a physician, as a clinician taking care of these patients, I've got 500, 15% are red. Those are the ones I really need to look at. That's 75 patients. And I don't have the time to go through patient 1, patient 2, patient 3, patient 4, when patient 68 may be my sickest one. Yep. And so that's an asynchronous model. There needs to be a mechanism by which I, as the healthcare provider, can prioritize, risk stratify, so that the technology risk stratifies my patients, tells me who is my number one priority of patient that I really need to look at. I believe what we have seen with the COVID and the use of telemedicine is patients have shown that they are actively engaged with their care. They will be actively engaged with their care. There are concerns, but I think of it the other way of if Bernie is one of my patients and she's supposed to be sending me data every day on whatever parameter, and I haven't seen a data set from her, does the system out of 500 patients tell me that she hasn't sent the data in, or if it's abnormal? But if she hasn't sent the data, is it because she's on holiday in Queensland, or she's laying on the floor for 3 days and hasn't had anybody there?
Very, very different scene, isn't it? A number of questions about sort of legal regulatory framework, and I've mentioned privacy, cyber security, but perhaps just to see whether Justin and Mukesh have got a comment. Australia's about to move into e-prescribing, and there's a long story behind that. I'm just interested about whether either of you got a view about how we manage the danger of how do we know that actually is the person that they say they are, and the issue about opioids and narcotic abuse. Any comments on that about e-prescribing? Should e-prescribing be part of telehealth, or only with a general practice and a specialist that knows the patient?
Well, I can. Oh, sorry, okay.
My very quick comment would be, you actually need to use all the tools available when you're using this environment, so you can actually get the next part of the consultation, which is providing potentially a prescription into the hands of the patient, and using electronic transfer of prescriptions is really an important part of that, although it's not perfect now. I would, however, say that when I did a roundtable of all the departments, and I did this, Tim, it might not have been possible in Canberra around telehealth, when we did this the first time round. Yeah. One of my colleagues said, you know, it really is me. Here's my credentials, a photocopy. I'm really a doctor. And that's how you get credential and have the right provenance of the person who's in front of you. So that's all very important, but that can be handled as long as we look at the bigger picture, the benefits, which is having the right tools to help you do your work better and reduce the patient's clunky interfaces with our systems.
Justin, a comment?
Yeah, look, and I want to sort of go straight to the heart of what you're talking about with, you know, drugs of addiction, for example. I think, you know, it's absolutely crucial wherever I am as a doctor that I be very, very careful with that. And you think about that, that's exactly the same as when I'm in my emergency department in my other job. We're very careful to say, look, A, let's try and avoid those completely, and B, it's up to the patient's usual prescriber. So we see a lot of patients in Victoria as well, and I have to give a shout out to that state for its SafeScript website, which is
the software checking system.
It's brilliant. So literally every time a patient calls us in Victoria and they want anything that sounds remotely sort of odd or squiffy, we actually look that up, because you have to.
Time, unfortunately, is beating us always, because it's always a great discussion. And just before handing back to Vern, is that people might know I'm also a lawyer. If you saw what lawyers have to do under the COVID-19 regulations to identify the client in a virtual signing of a will or some other documented advance care directive,
wow,
have a heart attack. Over to you, Bern. Sounds like a line from Insiders on the ABC on Sunday morning. Over to you, Bern.
Well, it does, yes. Back to you.
Sorry.
Look, thank you very much. It has been a very good discussion. I knew it would be, and I knew that we probably could do with about 3 hours. But what it means is, you know, I think whenever you get really robust discussion like this, is that it shows that there is a longer tail, and that now I'm back in farmer land. Something though that's come out that's been really consistent, even not just in the questions that have come through, and yeah, you did a great job of writing all of those questions into your questions for the panel, Tim. But you know, Paresh, for example, you know, he's asking, because he's like you, Mukesh and Justin. You know, you sit here, you're not just you know, part of the panel, you're about to turn around and go and start to treat patients as well for the rest of the day. And Paresh is just asking, you know, and I'm not going to make us go over, but it's a longer term question of, you know, how are you going to balance the tension between, you know, enhanced access and the continuity of care. And there's questions as well, you know, around interoperability, of course, and what we can do with telehealth and use it with our frail and vulnerable who are at home, and we want to be able to keep them there. And so what do we need to put into the homes? Who is the new workforce post, not just COVID, but post, you know, this year? The fact that we're finally just saying, okay, yeah, I think that we can use telehealth, and yeah, and the technology will be able to allow that. So I see a longer discussion. I'm going to pull this together as Mukesh used to have square table discussions, and I think that it's time, you know, for us to start to have those again with a project in mind, so an objective, you know, for delivery. And there's some great things happening, like Donna has, you know, in New South Wales Health with the Virtual Care Accelerator. You know, I asked Zoran Bolovic yesterday, well, how long do you think it's going to run for? And he said, well, it's not called an accelerator for nothing, Ben. It's going to be quick, and it is going to result in a panel of solutions that will be available to, you know, to New South Wales and to Australia. None of this can happen without it being national. You know, we've got to, it's really hard here at Erkin. We have this federated model, and if you look at Victoria, they're federated within Victoria to some extent. And a four-cornered round table. Thank you, Mukesh. So I'd ask for everyone, you know, to just start to think, all of the people who have attended today. You know, we've got 86 people, and I gather that you've all stuck around because you find this subject very relevant to your current practice, and just think about what we can do next. I have some ideas, and I'll share those over the next couple of days, but I'd love to hear from you as, you know, if we were to pull together a four-cornered round table, Mukesh, and what would we talk about to actually get things moving and we don't lose, you know, what we've got here is another model of care. And it is about just, you know, this is transformation. It's not going to hurt. It's going to feel really good because we're going to improve the healthcare outcomes. And yeah, it's, I mean, I'm looking forward to that Menzies document as well, Richard, when it's available. It'd be great if you can share with us, you know, what the benefits have been from RPA virtual care. So we will thank you again, everyone. I'm just humbled by the fact that, you know, we're able to bring you all together, and that you know, there's so much passion, and that you joined us today. So there'll be a questionnaire that will come out just so that we can keep improving. Of course, we will answer the questions that have come through, and Justin's already said, you know, we need to work on nationwide telemedicine guidelines to cover all facets. And okay,
we look forward to coming back in a few years where Ercan can help with the official opening of RPA virtual across Australia, and Richard will be surrounded by 2,000 screens, and Donna will be looking at them from remote New South Wales. Thanks a lot. Bye.
Thank you.
Thank you.
Thanks very much.